right, first we're going to talk about urticarial. This is your most common one. Have any of you seen this? Yes, please? It's about 1 in 100 at the widest range. So we expect to see urticarial transfusion reactions somewhere 1 in 33 to 1 in 100. How many transfusions do you guys do on your unit? Is it quite frequent? Yeah, so you should, we expect that you're seeing them. This is kind of our canary call, that if I don't see a certain rate of urticarial transfusion reactions, then that tells me that there's underreporting happening. There's not a whole lot that we can do to prevent some of this stuff. There's just an expected baseline. So having 0 transfusion reactions is not our goal. We want to see these reported because then that means I have good systems in place for making sure that people know what to look for and that they're reporting them appropriately. What are we looking for? Urticaria, obviously, pruritus, flushing, angioedema. What is the cause? Does anybody know? Obviously it's right here, but just off the top of your heads. Anybody? It's that a patient has antibodies to something in that blood product. When we draw a unit of blood, it's just whatever is floating around in your donor. So it could be something they ate for lunch or all kinds of different things that are floating around in that blood. This is the only transfusion reaction that you can pause it, stop the reaction, don't disconnect anything, call your provider, let them know, him or her know what's going on, and if they say go ahead, then you can keep going. Any questions on that? Yes,
Do you still do the workup?
absolutely, great question, thank you. So we'll still do a workup on it, it's incredibly minor though. So you'll order the transfusion reaction, I'll show you the computer steps in a little bit, that you'll order it, draw 1 sample, and we'll do a very minor workup on it just so it's reported that yes, this patient had this reaction, but you're allowed to keep going on it. All right, next is the most common, second most common is febrile. That's somewhere between 1 in 100 to 1 in 1,000. That one bumps it up the next level. This is fever, chills or rigors, headache, even vomiting. I've only seen 1 case, I think, since I've been here where somebody was having intense vomiting from a transfusion reaction, but that is an uncommon one. The reason this happens is there's cytokines and donor platelets or patient antibodies to donor white blood cells. So yes, we leukoreduce, but there still are a few white cells floating around in there. So again, anything other than urticarial, we have to stop. If they're having these reactions, we have to stop the unit. Even if the patient really, really needs blood, we need to stop the unit and make sure that there's not other things going along. As long as we're going through some of these, you'll see there's a lot of overlap between the symptoms. So while it seems obvious, yes, it's just a fever, those can mask other more serious things. You'll see later that some hemolytic transfusion reactions can start as fevers, so that's really what we're looking for, is making sure that it's not a more serious transfusion reaction that continuing to transfuse that patient would cause harm up to and including death. So very scary stuff. That's why we care so very much about it. Next, we're tired of talking about boring things. Let's talk about tacos. Taco, not the delicious tacos with lime juice. No. Transfusion-associated circulatory overload. So I heard your friend talking about you have a lot of elderly patients. Some of them weigh like 90 pounds. So if we put a whole bunch of fluid into them, you can get into this circumstance. My research said it was around 1 in 100. I will tell you, I do not see this reported very often. I don't know whether it's because it's underreported or because our docs are being good and telling you to do slower transfusions. So something to look out for. Things that happen here: dyspnea, tachycardia, hypertension, headache, and this really and truly is just a volume overload transfusion reaction. Questions on taco?
Do you still have to work this up as a
We
transfusion?
still have to work this up as a transfusion reaction because it looks a lot like trolley. Please don't say trolley. My medical director does. It is another way to say it, but I say trolley, hence my lovely picture here. So that is transfusion-related acute lung injury. That one is far less common, but you can see that some of the symptoms look really, really similar to where you have hypoxemia, hypotension. The tell on this one is bilateral pulmonary edema. You're obviously not going to see that just looking at it, but if they're starting to have shortness of breath, then our providers really need to be ordering a chest x-ray, and there's diffuse lung infiltrates. That's what we're looking for on this one. So the cause of that is that donor antibodies this time are going after something in the patient. For whatever reason, there's some research on this that's ongoing, that the antibodies in the donor are going after the patient's lungs. I don't know why it prefers those ones, but it just does. So that's why, even though taco, yes, you can manage that, it looks a lot like trolley, so we want to make sure that that's not what's going on in some of these. Questions on that? Simple, straightforward. Next, we have some of the scarier ones. Knock on wood, we don't see these very often, but we just want you to be aware of them. Hemolytic. This one, again, it starts with chills, so that can kind of look like a febrile one, but things very quickly start going badly to where they start peeing blood. And that's due to ABO incompatible blood types. It only takes a shot glass, 15 mils of the wrong blood type to get into this situation, and it can be very, very deadly. Next one is anaphylactic. That one, hypotension, stridor, bronchospasm. That one is patient antibodies. This one happens most often in IgA deficient patients, and we don't see that super often. As far as I know, I only have 1 or 2 patients that have IgA deficiencies that we've transfused. And last one is transfusion-associated sepsis. This is the one that we're most scared of with platelets. I hope I retire without ever seeing one of these. I'm hopeful that I'm very, very lucky in that. Platelets hang out at room temperature, so any critters that happen to be in there can up their numbers very, very quickly. So we can see it in other blood types or blood products, but most often it's going to happen with a platelet product. Questions on that? No? Couple other ones. These are more for the nerds in the room, and myself included. We have delayed serologic and delayed hemolytic. If you ever are looking through your patient's chart and you see one of these, this is that a patient has developed an antibody after a transfusion. So they've gotten a unit and then all of a sudden now they have an antibody. The difference between serologic and hemolytic basically is whether there's hemolysis or not. Both of them are that there's an antibody that's developed, it's just whether they're having a little bit of extra red cell destruction because of that antibody. And some of the common ones, E, little c, kid A, kid B, KEL, Duffy A, and Duffy B is what those stand for. A few of the super rare ones are transfusion-associated graft versus host disease. This is why we leukoreduce units these days. All of your units are going to be leukoreduced. It's going to be incredibly rare if we ever ask you to transfuse a non-leukoreduced unit. That's where the donor's white blood cells go after the patient. These are for in profoundly immunosuppressed patients. They don't have their own white cells. That usually the patient's white cells will attack any donor white cells in there and neutralize them. But if your patient doesn't have any white cells, then that process doesn't work normally. And so this one can be very, very bad and very, very deadly. And these symptoms don't usually manifest till much, much later, several weeks later, and they'll start getting purpura and things like that. Last one, this isn't super rare, but we just threw it in there for funsies. It's iron overload. If you have patients that are getting lots and lots and lots of transfusions, the body's not super great at getting rid of that extra iron that's held in those cells. So the cells eventually disintegrate and hemolyze and all that stuff as they're getting old and the iron hangs out. So if your patient's getting a whole lot of red cells, then they might be in this iron overload. I see that somewhat frequently on my oncology unit at PBH. It's something that we just have to manage. All right, so now you're all experts on transfusion reactions and symptoms, right? Right, cool. Now what do? You're gonna stop the unit, both physically stopping the unit and in Epic. You're at least gonna pause it, and then you're gonna call your provider, tell the provider what's going on, whether it's urticaria or they're having a raging fever or whatever the situation is. And then if the doctor says it's just urticarial, let the blood bank know. You can keep going. Great. You can keep going. You have to order a transfusion reaction, draw that sample, and send it on. Anything else, you have to stop. And this, we really wanted to emphasize that you have the power to say, no, I really can't keep going on this transfusion. The patient has a fever. We have had reports where a few providers are trying to get us to continue going on. We really can't. So if you're having any troubles with a provider that's refusing to comply with that, you're welcome to contact RISC, the nurse manager, House Soup, any of that kind of thing. It's compliance. This is all reportable things that we have to do for patient safety. Questions, comments, concerns on that? So know your stuff. If it's a fever, you have to stop. Okay? And please do submit an RL for all transfusion reactions. That's just another step to make sure that all of the workup got done and all the reporting got done. So to do the transfusion reaction documentation, these are teensy tiny. I'm sure your nurse manager is happy to send these out if you care. But here's how you do the reporting. Here's how to pause it, what that looks like, and then there's the suspected transfusion reaction. You can document your symptoms and all of that fun stuff. And then this is the order that you put in. It's just transfusion reaction. Gives us a couple little bullet points, and that will give you a specimen to draw one pink top. It doesn't have to have the witness initials and all that fun stuff. Then as far as what to send to the blood bank, if it's just the urticarial, it's just that pink top. If it's anything else, it's the pink top plus the whole transfusion set. I want the tubing, I want the saline. Are we allowed to put anything else other than saline with those units? No. Why? Does anybody know? What happens if you put glucose with a unit of blood? Or even lactated ringers? What? It causes clumping. It will gum up your lines. I have seen that once. Please don't do that. And then once it gets to the blood bank, we're gonna do a clerical check. That's just making sure that Mrs. Smith still is Mrs. Smith, that there wasn't some accidental, oh, we gave it to Mr. Smith. That is most often what causes the hemolytic transfusion reactions, is that there's been a misdraw somewhere. Happily, again, I haven't seen that here. We have some good processes in place, but that's the very first thing we're gonna check. We're gonna check to make sure that somebody didn't have a moment and accidentally put glucose or anything else that wasn't supposed to. We're gonna check for hemolysis or icterus in the patient sample and make sure they're not hemolyzing. We're gonna do a blood type, a DAT, and if the patient had a fever, we're gonna do a culture on the stuff that you just gave them to make sure that that wasn't contaminated. We talked about provider reluctance. One thing I do want to mention, this probably doesn't apply to this group as much, but anybody who does outpatient transfusions, or even if you had a patient that you gave them a unit right before they discharged and now they've gone home, if they call back and say that they have a fever, we need to make sure that this patient has good care. Yes, they should go to the ER, like they said, but I'm having some struggles with our ER docs ordering transfusion reactions down there. So that's, again, not really your problem, but just something to be aware of where we know that there's some gaps in the system.